with bear and wild dogs and everything,
Wow.
except tiger, but all other animals and birds and vegetations. It is lovely.
Fantastic. Mansi, can you start the videos, please? It's already 8:33.
Yes, sir. Actually, I had started. There is some problem because I checked, so I'm not able to start, sir. Uh, sir, can you check now?
Yeah,
Ah,
it's allowed.
I
Good.
think so.
Yes.
Accept.
Yes.
Yes.
Great. Good to see you, Dr. Purani.
Good evening. Yes.
Good evening. Hi, Rakesh. Is
Yes.
Devashish there? Devashish, are you there? Mansi, I think you
No, sir. Dr. Devashi.
has not yet come. Okay.
Yes.
I think
Should
you
I
can
open the room already, sir?
Please, please. Yeah. Because our
Yes.
speaker is
Okay.
there.
Okay. All right. Sir.
Or you want Dr. Purani to check his screen once and then open? Dr.
Okay, I
Purani, you
can
want to? Yeah, let's run the screen
share
sharing.
screen. Right. So, are you able to see the screen now?
Yes, we can see your screen.
Fine. So we can start now.
Great. So I think Mansi, you can open the room. Hello.
Yeah.
Hello, Mansi.
Yeah, Mansi? No,
Yeah, but she's opened the room. The attendees have started coming. Dr. Puranik will wait for a couple of minutes because she's open just now, so the attendees will start coming.
Yeah.
Hello. Sorry, sir. I got a phone call, so then I think you couldn't hear me halfway. So I was
So you
talking to
opened
Dr.
the room.
Devashish.
Yeah, you opened the
Yes.
room.
Yes. I have opened the room. Yes.
Great. So I think we wait for a couple of minutes and then we'll start.
Yes. And so we can also go live with this session, right? On
Yes,
YouTube.
Yes, we.
Sure.
Okay. So some students were asking for the YouTube session for 29th, which we deliberately did not go live. We said that we'll think about it and then
That was which one?
put it up later.
That was which one?
So Dr. Singh, he had shown videos
Oh yeah. Rakesh,
of.
you have reservations on that?
No, sir.
We can go ahead.
Oh, yes, sir. Yes, sir.
Yeah. So let's go ahead. Yeah. That's the muscle testing one.
Yeah, muscle testing we showed.
Yeah, let's go. We must show because that's very important for people.
Yes. Okay. So I'll put it up on YouTube then.
Yeah. And 8th October also you put up. So a lot of people were asking. So that's there.
Yes, that I have put up. So same link I had also sent to Rakesh sir and even Dr. Devashi.
Yeah. That is come, sir. That is come.
Yes.
Sir, next Thursday, should we conduct our Thursday meeting because it's the first day of Diwali? It will be 12th.
You want to give them a break?
I was just asking.
I think break will be better. No?
Yes, sir. Because even actually Abhay wanted to present, but he's going that day on leave, sir.
Yeah, a lot of people will go. So best to
I
give
think
it.
1 week we can keep a break and then we'll start again.
Yeah.
Yeah, because the
think
traveling and all. So
I think that's a good idea.
Yes, sir.
So shall we start? I think they will slowly keep coming. No? I think it's 8:37. So let's start.
We can start.
Yeah. Okay. Right. So, good evening, and let me welcome all of you to the Thursday evening clinics. I think today a very important topic is being covered, that is the speech disorders. I think these are important for the practical exam point of view, they're important from the neurology understanding point of view, and a lot of students find it difficult. So, luckily, today we have a very well known expert to discuss this topic with you, Dr. Apuro Paurani. He is a senior professor in neurology from Madhya Pradesh, and he's worked a lot on aphasia. He's written a lot on aphasia. His own work is there, and he's sort of been interacting with the top people in the aphasia field. So I'm sure you will benefit a lot from him. So welcome, Dr. Apuro Paurani, to these evening clinics, and we look forward to your deliberations. Over to you.
Good evening, everybody. Thank you, Dr. Satish Khadelkar, for kind introduction and giving me this opportunity to interact once again with residents, neurology trainees, and young neurologists. And I would be covering assessment of aphasia. Why this subject is important? It has high disease burden. You know, stroke is so common, and about 25 to 30% of stroke survivors have speech function impairment. Incidence and prevalence have been studied not in India but some other countries. The overall community burden is twice that of Parkinsonism. It has long-term morbidity and disability, and there is a lot of treatment gap. You might have heard the word treatment gap in relation to other neurological diseases like epilepsy, but the treatment gap in aphasia is much more glaring. So much can be done and it is denied. Aphasia has a very wide spectrum. It can range from mild and subtle to very severe. It can be predominantly motor, in which we call it efferent or expressive aphasia. It can be predominantly sensory, in which we say there is a problem with comprehension. The verbal mode of expression might be affected, the writing mode of expression might be affected, and the sign language, which is another mode, can be affected. Articulation may or may not be affected. In some aphasias, dysarthria can occur, while in others it may be absent. When we come to linguistic aspects, which part of the language function are affected, then we try to look at aphasia in terms of phonology, that is the sound patterns, semantics, that means the lexicon or the vocabulary and its meaning, syntax, which means the grammar and the sentence formation, and discourse means the longish conversation and paragraphs and monologues and all those things. And then whenever we assess a person with aphasia, we must not forget that other mental functions are likely to be affected, like apraxia, agnosia, amnesia, and overall cognitive impairment like dementia. So it's a very broad spectrum of aphasia. This is just a table to enumerate some of the disorders of speech, language, and communication. When we talk of disorders of phonation, then we call them dysphonia or aphonia, and they are mainly due to laryngeal dysfunction, which can be neurological and non-neurological. The next level is disorders of articulation. Anarthria, that means total loss of articulation, and dysarthria, again, it can be neurological and non-neurological causes. And then there are disorders of fluency, which are not aphasia. These are usually developmental disorders, and they are known as stammering or stuttering. And finally, there are disorders of language, which I am talking today, which includes aphasia, and disorders of reading and writing, which are dyslexia and agraphia. And I have already commented on the community burden of disorders of speech and communication. Time is needed. The assessment of speech function, you can't have a substitute for time. If you are not giving time with the patient, there is no justice. And we all are very busy. But there are some tips which can help. Of course, we need motivation, interest, and commitment on the part of clinician. The neurologist has to be knowledgeable about aphasia. More important is the practice, the drill, the experience. The more the patient with aphasia you examine, the more the patients you examine in a proper sequential methodological manner, it would be important, it will be helpful. Audio video recordings, if possible, should be attempted. So nowadays, in the current era of mobile telephony and mobile cameras, it is possible to have audio video recording. Of course, you should take informed consent. And if you have some help available in your office or in your department, particularly for some interesting cases, you can create transcripts from the audio video recording. And sometimes, for a practicing consultant or a neurologist, I give them an advice that they should train some assistants who are paramedic sort of people. So some sort of assessment can be done by them. And finally, we should keep testing materials handy. The testing materials in aphasia assessment are picture cards and scoring sheets. And nowadays is the era of digitization. So mobile apps can be created, and we are in the process of creating mobile apps. Very soon we would be sharing them. So all residents should carry the iPad or iPhone in which the assessment tools are there, and the scoring sheets can also be there, so that saves time. What are the purposes of assessment of aphasia? Of course, to begin with, we want to prove or we want to be certain that aphasia is present, and there comes the differential diagnosis. If it is present, how severe it is, then to explore its clinical profile. And the exploration of clinical profile can be brief, can be detailed and very detailed. It can be experimental and focused on a particular aspect. And then we look at what syndrome is there, if any. Apart from that, we are also interested in functional communication and quality of life. That means because of aphasia, how is the quality of life of person and his day-to-day functional communication has been affected. That is also part of our assessment. We also pay attention to caregivers. They are having the burden and what type of coping strategies they are using. We should not forget associated cognitive, neuropsychological, and psychiatric status. And of course, the purpose of assessment is to compare the performance of patient in a follow-up over a period of time as a result of therapy, without therapy, natural course. And then the purpose of assessment is research. And most important, this all detailed assessment guides our speech language therapist as to what type of practices, the therapeutic practices and rehabilitative measures will be advised to the person and the family that is guided by the assessment. So there are so many purposes of assessment. As I was telling about differential diagnosis, there are some conditions in which we should be careful not to miss diagnosis of aphasia when present. It can be missed when it is very mild, or it is evolving very slowly in some degenerative disorders. Some cases of sensory or receptive aphasia like Wernicke may be confused with hearing impairment. The attendants will say they are not listening properly, but it is not the hearing impairment, it is the sensory component of aphasia. Similarly, anomia is a very important feature of aphasia, and these patients will be brought by caregivers with the history of amnesia, that they are having memory loss. They are not able to name the people or person, but it is not amnesia, it is anomia. Similarly, people with aphasia, particularly those who have posteriorly placed lesions in the parieto-occipital cortex, they would have reading problems, alexia, and these people will go to ophthalmologist for visual impairment. And in very severe Wernicke's aphasia, the speech can be jargon, it can be fluent and yet meaningless. Such people can be confused with psychosis. They are talking irrelevantly. So these are some of the differential diagnoses. The other way around for differential diagnosis is not to make a false positive diagnosis of aphasia when it is not present. And the examples here are developmental disorders like mental retardation. So children and young adults who have been retarded right from the beginning, their speech function is not normal, that should not be labeled as aphasia. Stammering, I have said, it is not aphasia, it's a developmental disorders of fluency. Congenital deaf mutism is not aphasia. These people are deaf since early childhood and that's why they are mute. There can be neurological and non-neurological causes of pure dysarthria, but no language impairment, only articulation. This is not aphasia. Similarly, laryngeal disorders leading to dysphonia and aphonia, no language impairment, only phonation problem. This is not aphasia. Some children have regression of their milestones, including their speech and communication function, like in autism and autism spectrum disorder. That is not aphasia. There are many patients with visual agnosias because of occipital and posterior cortical atrophy. Because they fail to recognize the objects, they may not be able to talk properly, name properly. This is not aphasia. Of course, there can be functional disorders and psychosis, which can occasionally be confused with aphasia. And any person in altered sensorium, like in delirium, may have abnormal language function. That is not aphasia. In fact, one of the prerequisite for assessment of aphasia is that the person should be in normal sensorium, normal attention span. Before you proceed with the assessment of speech function, you make sure that the patient is wearing spectacles if needed. If the patient is hearing properly or not, you have to raise voice if necessary, or hearing aid are given. Instructions should be given very clearly. And if the patient having problem with paralysis or visual impairment, that should be taken care of. You should ask for handedness. You should interrogate caregivers and family members, and a general conversation should be started. Before we do this, we should enter our patient's demographic detail and clinical status. Important here is education, linguistic proficiencies, because in our country, majority of the people are bilingual or multilingual. So what is the linguistic proficiency in language 1, language 2, language 3? The date of assessment, the date of onset of neurological deficit, which will give you an idea that the date of assessment was so many weeks or so many months after the onset of illness, and the date of radio imaging, neuroimaging. So all these things are correlated. And you should also pay attention to stroke severity, that is the NIHSS scale, so that we correlate the language function with the stroke severity. We should interrogate the family members and attendants. And what type of history you will ask? Is the patient able to converse in normal manner? Has there been any change in the patient's speech? Can the person express himself properly? Is there any word finding difficulty? Does the patient replace some right words with wrong words? And is the patient able to comprehend speech of others? These are the type of leading questions, but you will wait for the caregivers to describe the patient's symptoms under these headings. And if they are not describing properly, then we will ask the leading questions. When you start talking to the person with aphasia, you should greet them, you should talk to them, and your assessment of a speech function starts right at that moment. What is your name? Where do you stay? Where are you now? What date is today? So this is the greeting and rapport development. And our assessment of speech begins right now. But then we should also pay attention to the handedness. And handedness means not only the hand with which you eat or write, there are more questions, about 10 questions which you should inquire because of the cultural factors. Many people who are non-right-hander, who are left-hander, they have been forced by their parents to take their meals with the right hand and to write with the right hand. But otherwise they are left-handed. So it is necessary to pick up the handedness correctly. And we know that 90% of the people are right-handers and they have the left hemisphere as dominant, and we will not go into that details. There are many testing methods. There are many testing batteries. Sometimes we use ad hoc or non-standardized method, but it is recommended for research purpose and also for documentation purpose, publication purpose, that we should have standardized and validated. And even for your exam purpose, the examiner may ask what method of testing you are aware of. And the most popular in India is Western Aphasia Battery, and another one is Boston Diagnostic Aphasia Examination. I will cover some of these things. These are the main headings under which we assess the speech and language function in a person with aphasia: verbal expression, auditory comprehension, repetition, naming, reading, and writing. And under each heading, there are large number of test items. There is a big list, but naturally time is a constraint. So a lesser number of stimuli is okay for brief screening and brief diagnostic purpose. However, a larger number of test stimuli, a more variety of test stimuli are needed for detecting a mild deficit, are detecting some critical variable on the performance, are detecting changes over time and effects of therapy, and also for research purpose. So you need more detailed assessment for research purpose. So coming to the first heading, the verbal expression. Here you are interested that we want to elicit a good sample of verbal expression. We have to engage the patient in such a manner that he or she is persuaded to give some longish answer. For example, who all are there in your family? What did you eat in the morning? Tell us about your illness. Describe your job work. Describe your diurnal day-to-day activities. And then finally, we use some pictures. And I will show you some pictures. The purpose of showing these pictures is to elicit a verbal response which is slightly longish. And it is a child's job. A 3-year-old child will describe what else is going on in this picture. This is a famous cookie theft scene in which I have done some modification in the dressing of the lady. And we expect the person to speak many sentences. And that gives us an opportunity how good is the verbal expression. Here is another picture created by an artist in my team. And here is another picture, same artist in my team. And here is another picture. So we can have standard pictures, and these are the props. They help us in generating a longish verbal expression. This is a lady with the purse scene, a comic strip in which some event is happening, and we expect the person to describe in a sequential manner what all is going on in this story. Having done that, what do we pay attention to? Ideally, we should record it, audio or video, and then get it transcribed, typed. Then we pay attention to fluency, which is a very important part. Is it a non-fluent aphasia or a fluent aphasia? And how do we decide? By information content, by the phrase length. That means the average sentence or average phrase is how much. In a case of Broca's aphasia, the speech is non-fluent. That means they use a telegrammatic language. Now the current generation doesn't know what a telegram is. So they speak in very small sentences, 1 word, 2 word sentences, and they try to convey the information in content words. We pay for attention to jargon. We look for paraphasia. By paraphasia, we mean, suppose he wanted to say mobile, and instead of mobile, he is saying something else, computer, or some unrelated or related word. That becomes paraphasia. In circumlocution, he wanted to say pain, but he say, that with which we write, so that becomes a circumlocution. And neologism, that means he speaks a word which doesn't exist in the patient's native language. And perseveration, that means he goes on repeating same answer again and again. So there are many abnormalities in the verbal output which are picked up when you are generating a good amount of verbal expression from the patient in the manner of history taking and in the manner of picture description. So verbal expression is the crucial aspect in the assessment of aphasia. Simultaneously, along with verbal expression, we look for articulation or dysarthria. Many patients with aphasia may have dysarthria, and for this purpose, we should have a ready list in our mobile or on our cards what to do. Otherwise, when we are really examining the patient, we forget what stimuli to give to the patient. If all these stimuli are with you in your mobile, you will be able to ask the patient, okay, please repeat after me following words, and you look for the articulation. And there are many types of dysarthria. I will not go into the detail. We classify them whether they are upper motor neuron, lower motor neuron, extrapyramidal, or ataxic, or cerebellum. So that's the classification of dysarthria. So After verbal expression and articulation, we come to auditory comprehension. This is a very important part of speech assessment in persons with aphasia. And how do we test it? We use picture cards, or we can use objects in the room, and we can use body parts on our own body. And how do we do it? We do it, where is this? If you are showing this screen to the patient, you will say, where is bicycle? And we expect the person to put her finger on the picture of bicycle. Or, where is your nose? And we expect the person to touch his nose. Or, we ask the person, where is the table in the room? And we expect the person to touch the table. This is the test of auditory comprehension at one word level. This means that when you utter the sound bicycle, the sound is going, the person is not deaf, it is reaching the auditory cortex, and then it is reaching the Wernicke's area where the meaning of that word is being generated, and the person has to correlate that meaning with the picture here on the screen. So this is a test of auditory comprehension. Of course, it can tag, or it can tag some other cognitive functions also, but this is our primary test of auditory comprehension. Then we also test auditory comprehension. One more precaution, that when we are testing this way auditory comprehension, nobody, neither the examiner, nor the doctor, nor the caregiver, should prompt the patient. We shouldn't look at the objects. Oh, here is the chair. No, we should look neutral. And then we give commands. They can be one-step command, two-step command, and we say the patient, I will ask you to do something, please do it. Open your eyes, close your eyes, and bring out your tongue, something like that. So two-step command. And we see whether the person is able to carry out that command or not. Patients with aphasia who are having problem with auditory comprehension will look bewildered. They will look confused. What is being asked of them? And that's the test of auditory comprehension. Then there are some silly yes-no questions. A child of 3 years will answer them laughingly. Does the stone float in the water? And we expect the patient to say no. But patients with auditory comprehension deficit because of aphasia, they look confused. They are not able to say yes or no to a question like, is the color of sky blue? And then they look confused. They are not able to say yes or no. So we have a list of such questions which are gradually increasing in their difficulty. That's a test of auditory comprehension. Another way is to narrate a small story. The story of tortoise and hare, or the story of a tiger and a rat. So you narrate a small story and then ask the questions based. These are all tests of auditory comprehension. Another test of auditory comprehension is, you say that here is a picture and I will speak 4 sentences, and you tell me which sentence is matching with this picture. And there can be a opposite. That means there are 4 pictures and 1 sentence. So till now we have covered verbal expression and articulation. Then we have covered auditory comprehension. The third part in the assessment of language function is repetition. Repetition is relatively simple, but it helps us in classification of aphasia syndrome. It also helps us in management. And the instruction we give to the patient is, listen carefully. I am going to speak some word or a sentence. You have to simply repeat after me. You start with easy, common, short words, and then you go to slightly difficult words and then short sentences. Some type of aphasias, they have difficulty in repetition, like Broca, Wernicke, and conduction. While some other type of aphasia, like transcortical motor, sensory, and anomic, they have relatively better preserved repetition. So that helps in classification of aphasia syndrome. Then this is the fourth. So first was verbal expression and repetition. Second was auditory comprehension. Third was repetition. The fourth step in the assessment is naming. Again, the same pictures. As I showed you in auditory comprehension, same pictures, same body parts, same objects in the room, table and chair and all those things. same figures and diagrams. Now the role will be reversed. Remember, what did we say in auditory comprehension? Where is bicycle? And we expected the patient to put her finger on the bicycle. Now the role is reversed. Now the examiner, the neurologist or the speech language pathologist would put her finger on the bicycle picture and ask, what is this? So this becomes naming. So if I ask and I touch my ear, I say, what is this? We expect the person to say ear. Or if I show him what is this, I expect him to say pen. So this is how we go on testing the naming. Again, I will remind, whatever testing you are doing, it is better to do an audio or video recording, or you should have a recording pro forma in which all these items are already printed. So your job is to fill in the blank. Did he name the tree properly? Yes, tick. Did he name the house? No, cross. Did he name the bicycle? Yes. So you go on putting tick and cross and tick and cross. So at the end of the scoring, you are able to tell what was the percentage performance of the patient. It is a wastage of time if you devote so much time in the assessment, but you are not keeping your notes. You all know, as a resident in neurology, notes keeping is so important. So in aphasia assessment, scoring and notes keeping is equally important. So that is about the naming. In naming, if the person is having difficulty, we can give them some hint. One of the hint is phonemic cue or sound cue. So if you are showing them a diary like this and the person is not able to say, you will help him. Oh, do you know? Do you know? It is called da, 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 da. So you give the initial sound and see whether he is able to get the word or not. Or if you are showing him another object like the spectacle or glasses and the person is not able, you give another type of help, which is known as semantic, in which you say, oh, that is the one with which we read, that is the one with which we see when our eyesight is weak, and we expect him to tell the word spectacle. Or another thing, we give him multiple choice. So if I show him this object, which is in the corona time, I put it on the face, and he is not able to name it, then I will give him multiple choice options. I will say, is it handkerchief? And I expect him to say no. I will ask him, is it a scarf? I expect him to say no. And when I say, is it mask? I expect him to say yes. That means the ability to reject and accept the answers. And sometimes we can give them written cues in which the same object's answer is written in a printed manner. So when a person fails in naming, we try to help him, and all this has to be recorded in our scoring sheet, that what was the performance, and performance without hint and performance with hint. This all is very important. Finally, we come to reading and writing. I will not go into the great details of the reading and writing. Reading and writing involves asking the patient, here are the pairs of printed words, and you have to just put a tick. This pair, is it same or different? So as you read here, ghar and ghar, it is same. Papa and bapa, they are different. So they have to put a tick mark like this, whether the pair is same or not. Similarly, we ask them to read the non-words. In the lower part of this screen, you are seeing some words which do not exist in Hindi language. Patient's ability to say, is it a word or a non-word? And we check his ability to read them aloud. So next function is reading aloud. So we give these, all these things should be there on your mobile. Otherwise, you are at a loss. And not only on your mobile, they should be there on your printed pro forma so that you are able to give the scoring and tick. So you give these words to the patient and you ask them to read aloud, simply read aloud. So there are words and uncommon words and short sentences and one syllable and two syllable and likewise, and you check the reading aloud performance. And then we check the reading comprehension. Something which we did for the auditory comprehension, those silly yes-no question, same questions, instead of speaking them aloud ourselves, we ask him to read. So he has to silently read the question and tick mark, is it true, yes or no, yes or no. So that's how you can test the reading comprehension. Another way of reading comprehension is to fill in the blanks in a sentence. So there is a sentence, there is a gap, and there are multiple choice options. and we expect the person to correctly select the option from the four things. And another way of reading comprehension, something similar to auditory comprehension, that you write a small story and ask the person to read it, and based on reading he should be able to read the questions also and answer them properly. And finally we come to writing, in which we ask him to write his name and address, we ask him to copy the sentences, and we ask him to transliterate from one script to another script, something like this. And then we give him dictation. We give him dictation of simple words and difficult words and numbers and non-words. And finally, the same picture which we used for verbal expression, we can use them for written expression. We say, look, here is a picture, see whatever is happening, don't speak anything, just write whatever you are seeing in this. So that becomes a written narrative. So these are the steps in the assessment. Now, based on the observations in these assessments, we try to make a diagnosis of aphasia. And if aphasia is present, the first question we ask, is it non-fluent or fluent, based on the verbal expression. In each category, whether it is non-fluent or fluent, the second question is, what is the repetition? And the repetition can either be poor or good. It can either be poor or good in this category. The third question you ask it, what is the auditory comprehension? And again, the auditory comprehension can either be poor or good. So ultimately you have 8 syndromes here: global aphasia, Broca's, transcortical motor, and mixed and Wernicke and conduction, and transcortical sensory and anomic. So this is the algorithm, and it is a 3-step algorithm. The output, is it fluent or non-fluent? The repetition, is it good or poor? And the auditory comprehension, is it good or poor? By these 3-step combinations, you get 8 answers on the bottom. And this is how you can make a fairly reliable diagnosis of aphasia. These are the salient features of major aphasic syndromes. I will not go into the details of aphasic syndromes. You can read them in the textbooks. Again, I will not go into the details of the anatomical site, what is the clinical picture, what is the anatomy. So Broca's aphasia is the classical example of non-fluent aphasia with dysarthria, word finding difficulty, agrammatism, and the anatomy is the inferior frontal gyrus, the posterior part and surrounding areas. In Wernicke's area, the lesion is in superior temporal gyrus, and they speak fluently, but the fluent speech is jargon, meaningless, not much content into it, but their auditory comprehension is poor. So that is Wernicke's aphasia. In global aphasia, there is a large lesion involving the temporal lobe as well as frontal lobe and arcuate fasciculus, and everything is affected in global aphasia, the expression as well as understanding. In conduction aphasia, the lesion is subcortical in the arcuate fasciculus, the white matter bundle, which is joining the Wernicke's area posteriorly and the Broca's area anteriorly. These people have mild non-fluency and mild defect of comprehension, but they have major problem with repetition. They can understand a big sentence from you. They can speak a halting sentence, but when you ask them, please repeat after me what I am going to speak, and you say, Bolo, Ram, Ram, and they're just not able to say Ram, Ram. So they're not able to repeat. That happens in conduction aphasia. And then we have transcortical aphasia, which are just opposite of conduction. Here they fail to understand, but they are repeating slavishly. Without understanding the meaning, in transcortical sensory, they will repeat the sentence verbatim while they will not be able to comprehend the meaning. And anomic is very common aphasia, in which the main problem is anomia. They have word finding difficulty, but otherwise their comprehension and fluency are preserved. And that is alexia without agraphia. These people have a problem with reading comprehension, but they are able to write. It's very interesting. So lesion is in the dominant occipital lobe and the splenium, which is joining the dominant occipital lobe with the opposite non-dominant occipital lobe. When that lesion occurs, these people have problem with reading comprehension, but they are still able to write. A word of caution here, that the classical aphasia syndromes have a lot of limitations. A large percentage, 30 to 40% of patients cannot be classified into these syndromes, and lot of overlap is there. And aphasiologists all over the world are now giving an advice that it is not fruitful to work hard to define the aphasia syndrome. It is better to go beyond them. And I here give the analogy from epileptology. There used to be an international classification of seizures. There used to be an international classification of epilepsies and epileptic syndromes, which we learned in the last 30 years. But in last few years, these classifications are under major revision, and more importance is being given to seizure semiology for each individual patient, for each individual seizure, and no pigeonholing. We don't try to fit the syndrome into one pigeonhole. Hence, something similar to epileptology in aphasiology, also we do not pigeonhole the patient's clinical picture into a particular syndrome, but we describe the aphasic semiology in a greater detail. Cognitive neuropsychological model of language has been evolving for last 3 decades. How the language function is organized in the brain, not so much in terms of anatomy, but more in terms of computational architecture, the functional architecture, which is described in terms of box and arrow models. That means the input comes here, then it is processed like this, and then it output is like that. So these are known as box and arrow models. They have their limitations, they have their utilities, and we try to examine and describe the performance of a person with aphasia in terms of this model. And these are the box and arrow models. I will not go into the details. So how the speech function is processing in the brain. Don't ask me what is the anatomical location of box A and box B and box C. There is no anatomical location or very poor anatomical location. And don't ask me what is the anatomical location of red arrow and green arrow and black arrow. There is no such correlation. These are cognitive neuropsychological models of language function. And nowadays, aphasiologists are trying to localize the lesion, not in anatomical terms, not in terms of MRI brain and imaging. They are trying to localize the lesion on this diagram. They say in this patient, the box number 3A and the arrow number 5A have been damaged. And there are methods of doing it. Why is it important? Why we are moving away from the anatomy? Of course, anatomy is important, but this functional architecture is equally important because it localizes the lesion in functional terms. And this impairment-based model is helpful in planning the therapy. So what type of therapeutic exercises will be given to the person? The assessment has to pay attention to these things, but I'm not going to the details for that. But for all these things, for all these batteries of assessment, we need a large resource pool of stimuli and test items. Today, I have shown you maybe 20, 30 pictures and words and printed sentences. What is actually needed is hundreds of stimuli, hundreds of test items. We need large word list in Indian languages. They should be classifiable in grammatical class, whether they are nouns and verbs and adjectives. They should be tagged in terms of their frequency. Frequency means the words which are very commonly used in our day-to-day life and the words which are less frequently used. They are mainly used in literature, something like that. We look at the words in terms of imageability. So when I say pen, it is an imageable word. When I say happiness, well, it is difficult to imagine happiness. It's a non-imageable word. We pay attention to phonological aspect. How is the sound? When it is written, how is the script? In which semantic category it belongs, whether it belongs to animals or plants or animate objects or non-animate objects or man-made objects. So these are known as semantic categories. What is the length of that word? So all we need a well classified word list and picture bank of such stimuli in Indian languages, which is a crying need of the day. That I have been trying to do at Indore. This is Hindi aphasia screening Indore test. It's a 5-minute test for screening of aphasia. Then there is a Hindi aphasia brief Indore test, which takes about 10 to 15 minutes. And then there is another test for reading and writing function, Hindi reading, writing, Indore test. So all these things are the need. Many other people in India are doing it. Some people have adopted the Western aphasia battery into Indian languages. Many Indian languages, Kannada, Bangla, and many other Indian languages, the adaptations have been done for Boston aphasia examination. Why do we need these resources in Indian languages? Not only Hindi, but all Indian languages. Because we, the clinicians, are often constrained by our imagination. We fail to marshal words and phrases and paragraphs which are needed for the assessment as well as care of a person with aphasia. We need the help of professionals from the linguistics and psychology. Some work has been done. A beginning has been made at many centers in India, and this is my probably last slide. So we have miles to go before when it comes to assessment of language function in aphasia. As I said, we need linguistics based resources in Indian language. We need neuropsychology and cognitive neuropsychology based resources in Indian languages. And all these stimuli and picture items, they will have to be standardized and validated with the help of normative data from healthy volunteers. A lot of work is being done. It has been done. We need image banks which are culturally appropriate for our country and different regions of our country. India is a subcontinent, and we need novel experimental test stimuli and methods for research purpose. And of course, we need digitization. As I've been talking today, we need digitization of these stimuli on iPad and our smartphones for assessment, including scoring and report generation. So a lot of work is going on. We hope that in coming months or years, these things will be available in a validated, standardized batteries and digitized versions. So we hope that the assessment of speech and language function will become easier for young trainees in neurology and young neurologists and practicing neurologists. Till that time, we have to use paper and pencil. Thank you very much.
Thank you. Thank you very much, Apurva. I think you made the difficult topic so simple. And I think it was a fantastic exposition. I think you have been working on it for so long that it naturally flows for you. Fantastic. I think there is a question that somebody wants to know whether there is a PDF format for this that the person can get. I don't know what is the answer for that.
The test batteries which I have developed, they are available in the PPT format, and I can share them.
Yeah. So if you give it to Dr. Rakesh, we will pass it on to attendees. Yeah. You know, I have always wondered about the polyglots, and when aphasia strikes them, how differently the languages go. So you want to say something about it? I mean, that's a very interesting area.
Yeah. I should have said, but then for the sake of time that I omitted it.
Yes, of course.
But it is a very important point. And as I refer to that, India is a multilingual country. And if a person with aphasia comes and we know that he is proficient in more than one language, we do the linguistic proficiency test. And the dictum is that the assessment of aphasia should be done in 2 or 3 languages on different days. So that's one thing. Similarly, when it comes to therapy, the therapy should be given in the language of patient's choice. So he says, this particular language A is important for my day-to-day work. I want to improve in that language first. So we will give the therapy in that. And a lot of permutation and combinations have been described. Which language will be affected, whether the mother tongue will be spared. That is the common dictum, common knowledge that the primary language is usually resistant to damage in brain pathology. But there are exceptions to this rule also. Similarly, the language which we are using at home versus language which we are using at our workplace or in our friends. So it depends on the salience or importance of the language in that person's life and day-to-day activity, that a given language may be affected more, may be affected less. A given language may be a better vehicle for therapy as compared to other language. So there are a large number of permutation and combinations.
Fantastic. It's a fantastic field of work. Rakesh or Devashish, any other questions?
Yes, sir.
Yes.
Sir, it was quite fantastic, sir. The way you put it so simply for the residents to examine bedside, it was absolutely fantastic. Sir, I wanted to ask you about the singing. Some of my patients who had a left MCA stroke, they will not be able to
Yes.
speak word, but they could sing. One of my patients was singing Kishore Kumar songs. So, what about singing and aphasia?
Uh, Aphasia is a disorder of dominant hemisphere, usually the left hemisphere. The music and singing and the tone or the prosody, that means the variations in the tone of our language, they are mainly governed by the non-dominant hemisphere or right hemisphere. So if that hemisphere has not been damaged, persons with aphasia are able to sing, they are able to appreciate music, they are able to comprehend music, they are able to compose music, they are able to generate music on instrument or in the vocal. And this fact that the music function is preserved in a person with aphasia is sometimes in some patients is used as a part of therapy. There is something called MIT, melodic intonation therapy. MIT. Melody means the musical melody. Intonations means you intone the voice or the language and the sound with the help of melody. And these people are taught to hum a tune or sing a tune or a famous song. And then having learned that, then they are taught to fit in the words of the sentence which they want to speak. So they are taught to make a parody of that song. So, but because the rhythm is preserved, they are able to put on the parody words onto it so as to express something instead of the original lyrics of the song. The parody lyrics are put in for the purpose of day-to-day communication. That is known as melodic intonation therapy.
I think Subhash is quietly listening. Subhash, you are the music master. Do you want to say anything?
No, I was just enjoying the talk by Dr. Pauranik. I mean, he's the master. And
Yeah.
when a master speaks, you have to just sit back and enjoy. That's what. Thank you. Thank you. I think that was great.
Sir, it
one
was a
question.
phenomenal lecture. Like it was such a nice and fantastic review. Within 1 hour, it's really amazing. It's for everybody, not only for residents. Sir, can you just tell us within, say, 5 minutes of OPD or bedsides, what is the quick examination that you do in your OPD for quick assessment, not the comprehensive battery? So if you have got, say, 5 to 10 minutes and we don't want to miss anything, so what should be the protocol?
The one I referred to was HACCP, Hindi aphasia screening indoor test. I will share that. There is one more which is more standardized and more validated, which has been done by ICMR project from NIMS, Hyderabad, Sushna Aladi, and Vashpol would know. They were basically working for development of assessment battery for vascular cognitive impairment, and assessment of speech function was a part of it. So it has been published recently in the supplement of Annals of Indian Academy of Neurology and Aphasia, which has been edited by me. So that article has been published by Avanti Paplikar and Suvarna, and we are all co-authors into it. So there is a Indian adaptation of a famous screening tool known as franchise aphasia screening test, and it is a very well validated. So that has also been published, and I hope it will be available in the form of a PDF or a PPT, which can be downloaded on our smartphones. So there are two versions for 5-minute assessment, one which was done by me, that is also standardized, but it has not been published, and the other one is the Indian adaptation of franchise aphasia screening test.
I would strongly recommend all the students to look at this Annals of Indian Academy of Neurology supplement on aphasia that Dr. Pauranik has edited. It's I personally found it a fabulous exposition of various areas. All of you to look at it. I think one more question has come, Dr. Pauranik. It's about role of cerebellum in aphasias. Role of
Cerebellum might have limited role in speech function. Of course, we all know that cerebellar ataxia will lead to dysarthria, but dysarthria is not aphasia. It's only a disorder of articulation. However, in acute large lesions of cerebellum, either traumatic or vascular, acute large lesions of cerebellum or short duration mutism can occur. The person stops speaking for a few days, maybe a couple of weeks, but usually it recovers. Otherwise, cerebellum has probably marginal or limited role in language function. It has a great role in articulation, but not in language.
Yeah. So any other questions, Devashish or Rakesh, or should we close at that?
Not
So
really.
just one question I wanted to ask.
Yes.
You said the role of these nonsense words, the words
Yes.
which are not there in our dictionary. So what is the role of that? Does it carry any localizing value if you check that?
It has a localizing value in that cognitive neuropsychological model of box and arrows.
Okay.
And I can show another model which was about reading and writing, similar type of box and arrow model for reading and writing. In those models, we want to determine the reason to particular box and a particular arrow. Then reading aloud of non-words and discrimination of a true word from a non-word, they are helpful in localizing the data, not in anatomical terms, but in that functional term.
Okay, sir. Okay. Thank you, sir. Thank you, sir.
Yeah. Thank you, sir.
Yeah. So I think Rakesh and Devashish are very kind and they want you all to rest next week. Is that right, Rakesh?
We
Yes,
can
sir.
take a break.
Next week is a holiday.
Yes, sir.
Yeah.
So I think all of you enjoy the Diwali and we'll meet after Diwali. Dr. Poranik, do enjoy your Diwali. Thank you very
Happy.
much for coming today and talking to us on aphasias. And if there are any questions that will follow, then one of us will
Yeah, yeah.
forward them to you. We can look at them.
Yes, sir.
So,
Yeah.
so it's time to bid good night. Subhash, good night. Good night,
Thank you,
all
sir.
of
Thank
you.
you.
Fine,
Good
sir.
night, sir. Good night.
Good night, sir. Good night. Sir. Thank you so much, sir. Thank you.